Hi everybody, my name is Will Daddario. The focus of this presentation is the 1963 Community Mental Health Care Act, which at the time was called the Mental Retardation Facilities and Community Mental Health Centers Construction Act of 1963. First, it might be, I think it's important to dwell on the original name there. The term retardation, which I think we all know now is perceived as derogatory, and it's actively not used either descriptively or medically. Perhaps in the original title, it signifies the social power structures that were at work at the U.S. during the time of the bill's passing. Specifically, we see that mental health was tied, conceptually at least, to a perceived abnormality or deficit or a lack in mental health functioning. This perception likely came in large part from the language of the psychiatry field. And so, even though people like Carl Rogers are doing person client centered work out there and spreading a different message, that language and that message I don't think has penetrated yet through the psychiatric institutions and certainly not the government. Second, the title's emphasis on the construction of mental health care centers hints at, I think, the aspirational nature of the bill, or the degree to which opticism rather than pragmatism or know-how was driving the passage of the bill. So clearly today, with so many hurdles still facing the mental health care field, we can see that the aspirations of the 60s stopped short of materializing, which is not to say that the act was not important. It did several things. One, it emphasized the leadership role of the federal government in providing care for those who had historically been institutionalized. And also, I think much of what we call and learned about this week as the continuum of care springs from this move of deinstitutionalization or dehospitalization, insofar as the distinction between hospitalized, inpatient, resident, outpatient clients really becomes thinkable with this 1963 bill. But I think, I'm a historian by training. I think it's really helpful to look at this 1963 act within a bigger legislative attempt. So I actually found myself gravitating towards information starting about 110 years earlier in 1854, when a woman named Dorothea Dix constructed and wrote a bill that sought a grant of land, a land grant from the U.S. government for, quote, the relief and support of indigent, curable, and incurable insane. Again, the language is interesting. Um, Dix herself was a really fascinating person who seems to be left off of the timeline, such as the one that we've got in this class and the one that we had in the ethics and professionalization class. She's an activist. Her title was Superintendent of Army Nurses for the Union Army during the Civil War. I strongly recommend that you look her up. But for the purposes here, I'll just note that Franklin Pierce vetoed the bill at the time with this message. He said, if Congress has the power to make provisions for the indigent and insane, the whole field of public beneficence is thrown open to the care and culture of the federal government. Things started to shift in 1954 with the passage of Title II of the Social Security Act and Disability Income Program. And really, when that was signed into law by President Eisenhower, you could see in it the seeds of Title 18, which was Medicare, Title 19, which was Medicaid, and Title 16, which was the Supplemental Security Income Program. And then again, of course, we're back to the 1963 Act. It's important to note that Nixon tried to dismantle it as early as his tenure in the 70s, but the Democratic Congress at the time stopped him from doing so. In fact, they passed additional requirements for the healthcare centers, but, and it's a big but, there was no funding attached to these requirements. And that's, I think, maybe the beginning of the practical struggles that would arise in the wake of the optimism that was expressed by Kennedy back in 63. It wasn't until 77, with Rosalind Carter, who chaired the Presidential Commission on Mental Health, that we start to see a move back towards putting the federal government in charge of big decisions like this. The findings of the commission that she was the chair of thought, yes, additional funds are absolutely required in order to fund the continuum of care. Because all these patients had been dehospitalized since the 60s and the 70s. And in fact, it was a persuasive argument. It led the way to the Mental Health Systems Act of 1980, but that was passed only 1 month before Reagan took office, and then it was squashed, and we didn't see any benefits from it. The last thing I'll say is that if we try to triangulate the 1963 Act within this larger historical continuum, it's worth mentioning that the architect of the 63 Act, who was a psychiatrist named Walter E. Barton, he had foreseen a lot of the difficulties that actually did arise. He originally pointed out several critical factors that were needed for the success of the Community Health Care Act. Precisely factors that we struggle with today, such as the need for aggressive aftercare, the need for long term administration of prescribed antipsychotic medications, the need for additional acute care hospital beds, and a need to monitor or somehow study the prescribing patterns of family physicians who didn't have the same formal training as psychiatrists. I think all those issues really continue, largely today because of the battle between insurance companies, money, and the demand placed on services, which is higher and higher every day. So ultimately, the 1963 Community Health Care Act was an important declaration of aspiration and a key factor in the nationwide dehospitalization. But the mental health care needs of the population have not been adequately funded, and therefore the aspirations of the 60s require a lot more advocacy today. All right, I hope that was interesting.